He's a consultant neuropsychiatrist based in Hyderabad. He's a medical doctor who facilitates speedy recovery for people suffering from mind-related issues like anxiety, work-related stress, depression, addiction, bipolar mood disorders, schizophrenia, marital problems, child psychiatry, anxiety spectrum disorders. He holds MD in psychiatry from Government Hospital for Mental Care, Vizag, and he is also a civil assistant surgeon, medical officer for Telangana state government.
Thanks for wonderful presentation, Ramakrishna sir and our urologist. So we have a multidisciplinary team. We deal with particular organ, but what psychiatrist will deal? So always a question. Except from psychiatric organization, CMEs, we know what we deal, but other than that, like multidisciplinary team, what psychiatrist will deal? That's the question. So of course, in later slides I will show. So with a brief introduction of psychiatry and diabetes and mental health, so I will go into the topic. So in introduction, I'll go with an evolution. How was evolution programmed the endocrine system? Evolution has major role in guiding the metabolic pathway and hormone action. In evolution, humans have faced scarcity of food, warmth, water, salt, and calcium. Of course, these are the stress parts of what our ancestors faced. So, evolved to conserve this limiting. So, in evolution, what happened? Four hormones to increase the glucose. That is glucagon, cortisol, and growth hormone epinephrine, and one hormone to decrease glucose. That is insulin. Of course, yesterday I saw the insulin pump and artificial pancreas. Of course, God has not created that. Team, like technical team, created that. So about history, the relation between mental health and endocrine system or diabetes. So the interface of diabetes and psychiatry has fascinated both endocrinologists and mental health professionals years together. So in 17th century itself, Thomas Williams speculated that diabetes was caused by long sorrow, that is nothing but stress. Sir Henry Maudsley commented that diabetes is a disease in a families in insanity. So there is a therapy called insulin coma therapy was used as a psychiatric treatment previously. So with this brief introduction, so which comes first, diabetes or mental health disorders? Like we say, more common is depression. So it's a bidirectional association. If diabetes established, obviously most of the patients are going. Of course, we come across the epidemiological evidence, what are the patient, how many patients we get the depression when they go to a diabetes, and how many patients of psychiatric disorders may get diabetes, but it is bidirectional, even they are individually present in the patient. So major psychiatric disorders like major depressive disorders, either schizophrenia, either bipolar, all may lead to diabetes. It's a reciprocal, like major depression may lead to diabetes, diabetes lead to a major depressive disorder. So mental illness increase the risk of diabetes and diabetic complications. Major depressive disorder increase the risk of type 2 diabetes by 60%. So why it happened? Because of non-adherence to medication and self-care, and functional impairment, risk of complications, healthcare cost, and risk of mortality, early mortality. So depressive symptoms are present in 30% of the people with diabetes. So major depressive disorder, so-called clinical depression. Of course, when we encounter the patients, we see a subclinical depression too. So here I'm going to talk about major depressive disorder. Occurs in 10% of the people with type 2 diabetes, which is double the rate in general population. Usually general population may have, general population, we see 6% as per WHO guidelines, WHO predictions, there are 6% of population are depressed, but in diabetes 2, there is 10% of population who go to major depressive disorder. So comorbid depression worsens clinical outcome in type 2 diabetes because lower levels of physical fitness and reduces medical adherence, medication adherence. So what is the major, as we are discussing about diabetes and mental health, what probable cause in diabetic patients lead to depression? This is nothing, we have to evaluate the diabetes distress. What is diabetes distress? Diabetes specific, it's also called as diabetic specific distress or diabetes related distress, is an emotional response to living with diabetes, the burden of reluctance, daily self-management, and its long-term complications. Obviously, once patients come to clinic and diagnosed with pre-diabetic or diabetic, these are the things they will go through usually they are going through these kind of questions and mistrust. Obviously there is a social impact, like stigma, yeah, stigma and discrimination and dealing with other people, and even financial issues, how to deal the medication things and hospitalization self care issues. So how we screen depression or this kind of diabetic distress in diabetes? So there are screening tools, like distress scale, and if we have a paid scale also, and quality of life scales WHO 5, and depression and anxiety scales, Beck's anxiety or Beck's depression inventory kind. These are the scales we can use to evaluate and assess the depression and anxiety in diabetes patients. And once we came to the diagnosis that patient having diabetes and of course depression, so what are the treatment modalities? Directly we don't go to medications per se, because obviously they are using medication for diabetes. So most of the my patients prefer not to use any medication. They want only a kind of therapy. So we prefer cognitive behavioral therapy, and of course other types of psychotherapy. Most of all, talk therapy. What is talk therapy? You just talk with the patient and know the consent of the patient. So and clear that myths what they have, and of course we have to talk with family also to clear their myths and how to take care of these medications, and even financial things also we have to address. So it's a simple talk therapy, I would say, like. And of course finally, if they are not recovering and still they don't have any lifestyle modifications, still they are not having any medications, not following any protocol, then yes, we assess and we diagnose and we go for antidepressant medication. So the features of cognitive behavioral therapy in diabetes treatment. So this cognitive behavioral therapy has a two components. One is cognitive component and behavioral component. What cognitive component deals with and how to do this? So we have to uh, give the patient a glimpse of the treatment protocol and lifestyle changes and everything, and let them record the uh, thoughts what they have, and record the myths what they have, and record keeping to by this we identify the distressing automatic thoughts. So, for example, if they have insulin, so most of the people, if they have insulin, they think that it is a lifetime therapy, and it gives a mox and kind of in abdomen or somewhere else. So we have to get the thoughts, what they are, what distressing facts they have. So we have to deal with that, understanding the link between thoughts and feelings. With that they won't go out, they don't mingle with the socialization comes down. So usually they avoid people, they don't go for party, even that is a stigma. So we have to address that, learning the common thinking errors. So we have to clear it, and analyzing negative thoughts and promoting more functional one. That's about the cognitive component. And behavioral component, strategies to help get the person moving, behavioral and activation, and scheduling pleasant and meaningful events, and focusing on feeling of mastery and accomplishment, learning problem solving strategies, and of course exposure to new experiences. We have to promote them to go out and mingle with the socialization and improve their lifestyle. So, what are the other psychiatric associations with diabetes? Of course, we have mood disorders. Here, of course, depressive episodes or manic episodes will be there, and anxiety disorders, and of course, eating disorders. So, we shouldn't forget about the substance use disorders and schizophrenia, and of course, other psychotic disorders. So, apart from other psychiatric disorders associated with diabetes, even psychoactive medications may lead to diabetes. So, especially atypical antipsychotics, which they use for a long term in a psychiatric patients, may lead to diabetes because metabolic changes. And of course, who is using these psychoactive substances, substances, well, obviously there will be a lifestyle changes factors. They are sedentary, they don't go out. These are the lifestyle factors which may lead to diabetes. And comorbid mental illness often worsens diabetes control and causes earlier and more serious complications in later life. So, keeping this in the mind, so when we start the psychiatric medication, we have to do metabolic screening. So based on time based, these are the time based. Baseline, we of course these are the simple measures like weight, BMIs, waist circumferences, BP, fasting blood sugar, lipid profile, and of course family history and their recreational drug use. These are the baseline investigations, and even every month they come for filling of medication. We have to do at least BMI, and every 3 months we have to do waist circumferences and H1A1C and lipid profile, and at least we have to ask if they are increasing any smoking habit or alcohol intake. And every 3 to 6 months, lipid profile and H1A1C and weight. Annually, we have to take family history too. So, yeah, if there is any changes because of the stress, even family members get involved to get depression kind of. So, what is the interaction between diabetes and psychiatric disorders? As I said, present as co-occurring independent conditions with no apparent direct connection. Uh, Diabetes has a risk factor for developing of psychiatric disorders, and psychiatric disorders has a risk factor for emergence of diabetes, overlapping clinical presentation of diabetes and psychiatric disorders, interaction of medications, and impaired treatment adherence. And yeah, most of the patients who are pre-diabetic level or diabetes, so they are comorbid with tobacco use or alcohol use. These are the few recommendations in at least a primary care has have to deal with. Like they have to ask for a addiction probabilities of smoking or alcohol, and we have to understand the 5 A's and 5 R's. So once the patient comes to you, and at least we have to ask for 5 A's, that is ask every patient and every visit about tobacco use. It has that importance, and advise strongly all users to quit. Assess the patient's willingness to quit, and assist patients in their effort to quit. Arrange a follow-up close around to quit date. These are the 5 A's we have to ask the patient. And 5 R's, relevance of quitting specific to the patient, risk with continued use specific to the patient, reward of quitting specific to the patient, roadblock to quit specific to the patient, repetition of the previous steps. So what specific patient? Yes, there is no protocol to deal with each and every patient. We have to talk and know their concern, why they are smoking. So we need to deal. So there is a specific approach to each and every patient. So, and what are the recommendations with regard to alcohol use among diabetes? Alcohol, so person who is taking alcohol weekly once, and of course suffering with diabetes, so whether we have to treat that condition, this is the question we usually I get. So first we have to assess whether they are in addiction. There is a few criteria to assess whether they are addicted to alcohol. But in a primary care, at least we have to go through few questions like cage questionnaire, have you ever felt the need to cut down on your alcohol drinking? This is the first question. So if they say that I don't drink much, but yes, I don't want to quit. Yes, that triggers our uh, support. Okay, and have people annoyed you by criticizing your drinking? Have you ever felt guilt about drinking? Have you ever felt, this is early eye opener, early morning drinking? If we have two questions positive, then yes, we need to refer to a psychiatrist, and particularly these people need psychiatric support to quit their alcohol. And with this brief, I would like to give a few key messages regarding to diabetes and mental health. Living with diabetes associated with concern specific to illness and diabetes distress, psychological insulin resistance, and fear of glycogenic episodes. So we have to address that. People living with diabetes and depressive disorders increase the risk for earlier or all-cause mortality compared to people living with diabetes without a history of depression. Key messages. All individuals with diabetes should be regularly screened for the presence of diabetes distress as well as symptoms of common psychiatric disorders. Common psychiatric disorders, I'm not mean to say for schizophrenia kind of, but at least substance abuse. Compared to those with diabetes only, individuals with diabetes and mental health concerns have decreased participation in diabetes self-care, a decreased quality of life, increased functional impairment, increased risk of complications associated with diabetes, and increased healthcare cost, obviously. So, cognitive behavioral therapy, patient centered approach like motivational interview, as I said, talk therapy, and stress management, coping skill training, family therapy, and collaborative case management should be incorporated into a primary care itself. So, self management skills, educational interventions that facilitate adaptation to diabetes, addressing co occurring mental health issues, reducing diabetes related distress, fear of hypoglycemia, and psychological insulin resistance are all helpful in successful managing the diabetes. Individual who are taking psychiatric medication obviously benefit with the regular screening of metabolic parameters, as we discussed previously how frequently we are to do weight thing. Apart from to that, glucose dysregulation, dyslipidemia, hypertension, and weight gain throughout the course of illness, so that appropriate interventions can be. And few key messages to the people with diabetes who is living with diabetes can burdensome and anxiety provoking, with constant care demands taking a psychological toll. As a result, many people experience distress, decreased mood, and disabling levels of anxiety, distress over the self regimen, and stress in relationships like family and friends, and even healthcare providers. Even some people don't trust on their physicians that he is treating me well, though he is giving a list of tablets. I am not getting control of diabetes. These are the things we have to deal. For the patient, they have to approach a support who gives a clarity about that. Mental health disorders can affect your ability to cope with and care for your diabetes. It is just as important to look after your mental health as it is your physical health. People diagnosed with serious mental illness, such as major depressive disorder, bipolar disorder, and schizophrenia, have a higher risk for developing type 2 diabetes than the general population. So, acknowledge emotional response. Talk to friends, family, and diabetes healthcare team about the feelings. Team can help to learn effective coping skills and direct to support services that can make a difference. Mood and anxiety, eating, and even sleeping disorders and stress-related disorders are particularly common in patients with diabetes. Speak to healthcare providers about these many concerns. So this is my last slide. So a multidisciplinary team are needed to obtain optimal medical and psychiatric outcomes for the people with comorbid diabetes and depression. The patients and healthcare providers to the patient should be entrusted with the responsibility of shared decision making, so that even their financial concern and relationship issues can be dealt during the treatment of diabetes and of course mental health disorders. Thank you.
Thank you, Dr. Sunil, for a very mind stimulating talk. I have a question. You said a lot of correlation between patients with antipsychotic medications and diabetes. So, what screening do you do when your patients are on antipsychotic medications? And is there one against the other which is more predilected to cause diabetes?
Yeah, especially, madam, when we initiate any antipsychotics in a psychiatric patient, we have to screen the patient of for metabolic disorders, and of course, each and especially antipsychotics like atypical antipsychotics may lead to a metabolic disorder. So, but every patient won't affect with this kind of. So, if we screen regularly, if we change the drugs regularly, we can't find like they won't go into a diabetes. Especially olanzapine and clozapine are most common drugs which may lead to diabetes in psychiatric patients who are taking regularly, at least more than a year or two. Yes, sir.
Okay. Do you have any specific tools, tech-based tools for assessment of stress and mood disorders?
Excellent, sir. Thank you. So, yeah, as the platform is for technical people, and yeah, we are going through artificial pancreas kind of. If there is any technical support for to assess the depression or anxiety in a people, so as a traditional method, we have to talk with the patient, and we have a list of questions to ask them, and we get whether they are depressed or if they are going through a kind of anxiety thing. So yes, as the question, like there is a technical support, there is a technology to assess depression. Yes, there is a biofeedback mission, so which assess the depression and anxiety by taking 5 parameters like pulse, heart rate, respiratory rate, and of course skin temperature, and how we respond to the question kind of they assess, and it takes time like half an hour to 1 hour time, and if there is any changes in these measures, yes, that gives a clue that yes, person is going through anxiety or depression. With that, I would say like it's not a gold standard method, but if you give a medication for a patient with a depression or anxiety, we get the biofeedback thing, and after a month giving cognitive behavioral therapy, and then if they go through again that biofeedback, the parameters are very less and good improvement. So for the prognostic view, we can take that biofeedback as a assessment. Yes,
What
yes, sir.
about
Thank you.
what about stress?
Yeah, that's why. Actually, in psychiatry, there is no word or disorder like stress, but the stress, what we name it as depression or anxiety. So, with biofeedback, there is a feedback that yes, this guy is doing better with his whether he is having stress also, he is doing better, and he has good coping strategies to do that, and he can able to manage that stress. We can give that feedback. Yes,
Uh, I have one question.
yes, sir.
You know, there is one condition called as a diabetic raise.
Diabetic race.
Yes.
Yes.
For that, is there any preventive measure, like any tablets? How long we have to take treatment?
Uh, as we discussed, depression is a spectrum
Anger,
of.
anger. That's just anger.
Yes,
Not depression.
yeah, it's a spectrum, sir. It's a depression as itself is not a simple depression, a low mood. It may lead to a kind of rage like anger to low mood. So there may be a mixed anxiety and depression also. So it's a spectrum. It's a kind of anger to low mood. So first, we have to address that anger. If every patient comes with an anger or raise, we can't give directly a medication. So we have to assess whether it is a first incident he is going for a raise or anger. So if it is persistent for more than 2 weeks, then we treat it as an anxiety patient, or we can give anger management therapy kind of. Then if it is not getting down, then we can think of medication. Yes, antidepressants are the main medication for to control this anger. Yes, the anger may related to psychotic spells also. In that, we have to go for a antipsychotics.
Do you think there are any anti-angry tablets?
Great. So, uh, anti-anger medication. So our tranquil speech itself is a medication for them. I think, yeah, tranquilizers make them sedate, no doubt. But once the sedation comes down, obviously they become uh, paranoid, kind of. Yes, they become more anger. Usually, sedatives are not prescribed in psychotic things because they may lead to anxiolytics. Even sedatives acts as an anxiolytics. We can give it for a transient period, not for a longer time. It's an anger issue, so we have to uh, give cognitive behavioral therapy. We have to talk with them. We have to clarify the issues, and if it is not getting down, if he is not changing his behavior, then we can go assess for psychosis or things, and we can go for a medication.